All right, we're right on the hour, so we're going to get started. Good morning, good evening, good afternoon, everyone, wherever you may be. My name is Quentin Eichbaum, and I'm the co-chair of the AFREhealth-CUGH Working Group, and I will be moderating the session today, as we do when we have the meeting at CUGH, and when it's at AFREhealth in the other part of the year, it's moderated by AFREhealth. So I'll give a brief introduction to what this is about and then hand over to Abigail. The ACWG was founded in 2017. This is the 5th year, still going strongly. The idea was to bring together the two organizations into a partnership. CUGH has been going for 10 years. AFREhealth had started at that point. But the president of AFREhealth, Abigail Gazemba, will be telling you a little bit more about the background of the two groups, of the AFREhealth group mostly, and how we came together. So just in terms of the logistics of the meeting, after I've gone through the agenda, which you can see projected here, Abigail will talk, and then we will have a keynote address by Professor Jimmy Volmink, and we are very grateful that he agreed to do this for us. He's former Dean of Medicine at Stellenbosch University in South Africa. He will be introduced by Elsie Kagula-Mawade, and the topic of his talk, as you can see highlighted on the agenda in front of you, is Reflections on Global Health in a Post-Pandemic World with a Decolonized Mindset. That is what we asked him to speak about. It's a very tough topic, and there are few people who could do it as well, I think, as Professor Volmink. After his talk, which is around 8:40, Zoe Mullen, the editor of Lancet Global Health, very kindly agreed to provide some comments and to lead the Q&A. She's also superlatively qualified to do that, having monitored many of the submissions to her journal and having a finger on the pulse of what's going on in global health. Around 9:10, we will break up. We'll have report backs from the 3 subcommittees of the ACWG by one of or 2 of the co-chairs you can see listed there. We will then have the breakout sessions, which will last from 9:30 to 10:30. Choose a breakout session. There will be 3, either research, education, or student exchanges. And hopefully we'll be fairly well divided between those 3 groups. But if you've worked with one of them and your interest is in one, go for that group. Or if you want to learn from another group, go into that particular group. At this stage, we're allowing people to choose the group they want to go into. Around 10:30, and the satellite as a whole is 3 hours long. We will come back for short report backs from each of those subcommittees. And the idea of the breakout is to decide the path ahead. And we're all cognizant of the fact that we've been through a 2-year pandemic and haven't met in person. And hopefully this year we may meet at AFREhealth in Zimbabwe again, but to plot a path forward for each of those groups. After the report backs, we'll have time at the end, about 10, maybe longer, 15 minutes, to decide on some next steps for the ACWG as a whole. So that's the agenda for the day. It's tight. I'll keep track of the time. We have technical assistance from Confex, from CUGH. But for the question period, during and following the keynote, please put your questions in the Q&A, and you can also verbalize them if you prefer. So there will be 2 options: either put them in the Q&A and one of the facilitators will read them out, Zoe Mullen or Elsie, or otherwise you can put your camera on or keep it off and speak out on the platform. So that's what we have here for today. As I said, I'm the co-chair. I'm a professor at Vanderbilt University Medical School. I was born and grew up in Africa, know the continent very well, and I'm on the board of CUGH. So I'm the CUGH end of the ACWG. Elsie Kagula-Mawade and Abigail Gazemba are the incoming and outgoing presidents of AFREhealth, and they will be playing a major role in co-facilitating this meeting. So without further ado, I'm going to ask Abigail Kazemba, the current president of AFREhealth, to speak about the background to the ACWG. Very briefly, we do this each time just so people know what we're about and where we've been. Abigail, are you still there?
Yes, I'm still here.
Okay.
Are you going to share the screen?
All
right, I'll share. Oh, it's saying you cannot.
Oh, can someone put up Abigail's slides for her? Let me see if I can.
Could you please stop sharing?
Okay, I'll stop sharing. Okay, there we go. There we go. You should be able to put it up now.
Okay, let me try again. Can you see my screen?
Yes, perfectly.
Okay. Good afternoon, good morning, good evening, and welcome to this session. As already indicated, I'm Abigail Kazembe from Kamuzu University of Health Sciences in Malawi, the current president for AFREhealth. I'm going to share with you about the background of ACWG. Looking back, we had a conference workshop during AFREhealth Symposium in Accra, Ghana in August 2017. And we gathered to get to know the partners and tested their interest in this kind of venture. There was a pre-conference satellite meeting in 2018 at CUGH conference, which was held in New York in March, where we explored possible areas for collaboration and areas, we distilled the areas that were explored. The conference workshop at AFREhealth Symposium in Durban, South Africa in August, the same year, we reviewed those distilled areas and narrowed down to 3 working groups and formed the 3 volunteer jumpstart groups. I will briefly show you the diagram for those groups. And in 2019, there was a conference workshop at AFREhealth Symposium, Lagos, Nigeria, where we reviewed work done and plans for 2019 and 2020. And it came 2020, we never had any face-to-face meetings because of COVID-19. But we've had pre-conference satellite meetings at CUGH, and that was virtual. So here you can just see a picture of the grouping that initiated the discussion and they built it on.
Abigail, your slides are not moving. Perhaps you may want to move.
They're not moving?
No.
Oh. So maybe I don't put them in slideshow. Can you see?
There we go. Yes, now we see them.
So I'll not put them in slideshow. So I hope you can see the picture.
Yes, we can see it.
Abigail, if you could share, if you could start from the beginning and go into slideshow, so it'll be full screen, that would be great. Thank you so much.
Should I go back?
Yes, go
Sorry,
back.
I did.
And then click on slideshow, please.
You can see that one is in slideshow.
Yes, we'd like to see it in slideshow so that it covers the entire screen. Thank you.
You can see the second one.
No, just click on slideshow on your menu, your toolbar on top.
It's in slideshow now.
Okay, and then it should say you should be able to click on it from the beginning. I can't see your toolbar.
Can you see that one?
I think just continue.
Yeah, just continue.
It's not following your instructions. Just continue, please.
Okay. So we were showing some of the activities that took place, conference workshops, There were small group discussions, satellite virtual meetings, and we also held discussions with AFREhealth Executive Committee, and made a presentation to AFREhealth Governing Council. And because of distance, we also held a lot of online discussions on the same. So the distilled areas of interest were those reflected: education for health system strengthening, health professions education capacity development, student exchange, research capacity development, leadership development, interprofessional learning. All those, we were hoping that we'll end up with working groups or special interest groups. We reviewed those distilled areas as indicated and narrowed down them to 3 working groups, and we formed 3 volunteer groups, which are reflected there: research and internship, interprofessional, health professions education, and student exchange. So that's what is making up this ACWG. Members were registered for the groups, and each group was asked to come up with the terms of reference and also a listserv for easy communication, tentative work plans, methods of work, and also the held meetings. So this is how ACWG came into being, and we believe that if you want to go fast, go alone, but if you want to go far, go together. This is an African proverb, and then we don't leave anybody behind. So briefly, that was a brief background to ACWG. Thank you.
Thank you, Abigail. Right on time, it's got a minute or two. So that was just, as you see, a brief introduction, how we started. Anyone can join AFREhealth-CUGH Working Group, join one of the 3 subcommittees, contact myself, Abigail or Elsie. I will also state, seeing we have a minute or two, just add to that, that I will be the outgoing chair, and a new chair, Catherine True from Stellenbosch, will take over on the CUGH and after this conference. So I'd like to ask Elsie Kagula-Malwadi at this point to introduce our esteemed keynote speaker, Jimmy Volmink. Elsie?
Okay. Thank you, Quinton. Elsie Kagula-Malwadi. I'm from Kampala, Uganda, and I'm the Vice President of AFREhealth. It is my pleasure to introduce to you our distinguished keynote speaker, Professor Jimmy Volmink. Professor Volmink is a professor in the Department of Global Health and a former Dean of the Faculty of Medicine and Health Sciences at Stellenbosch University, South Africa. He previously served as the founding director of Cochrane, South Africa, and the South African Medical Research Council, also founding director, Research and Analysis, Global Health Council, Washington, D.C., and Clarkson Wellcome Chair of Primary Health Care at the University of Cape Town. He began his professional career as a general practitioner in Swaziland and around the townships near Cape Town. He was awarded a Harvard South Africa Fellowship and obtained an MPH from Harvard University. He also obtained a doctorate of philosophy in epidemiology from the University of Oxford, after receiving a Nuffield Medical Research Fellowship. Professor Volmink's special interests cover a career extending over several decades, including evaluating the effects of health interventions, promoting evidence-based decision-making, addressing health and social inequities, and building research capacity. He's an elected member of the Academy of Sciences of South Africa and an elected fellow of the Royal College of Physicians of Edinburgh. He has also received the Liverpool Medal of Distinguished Contribution from the Liverpool School of Tropical Medicine and a recognition award for his contribution to evidence-based healthcare in Africa from the South African Medical Research Council. In 2021, Professor Volmink received an honorary doctorate from Belgium in recognition of his work to promote human dignity and his contribution to science and practice to improve health and well-being. In the same year, he received the South African Medical Research Council President's Lifetime Achievement Award. Please join me to welcome Professor Volmink to give us the key presentation. Professor Volmink, you are very welcome to give us your presentation. Thank you. Over
if I can just interject quickly, for those who joined late, Professor Volmink will speak now. If you have questions, put them in the Q&A, or you can keep them and verbalize them at the end when Dr. Zoe Mullen moderates the session. So Professor Volmink, over to you. Thank you.
Thank you very much, Elsie, as well as Quentin, for your kind words, and hello, everyone. It is really an honor for me to share a few words with you on this topic, which, as Quentin has pointed out, is not a particularly easy one. Reflections on global health in a post-pandemic world with a decolonized mindset. I thought that I'd start by just commenting on the title itself. It's meant to be reflection, so it's about sharing some thoughts on something, and not necessarily about providing any answers or solutions. So my talk will therefore aim to identify some points for consideration, which I hope we can take up in the ensuing discussion. A further term in this title is global health, and this is a term which is
so Jimmy, sorry to interrupt you, but if you can talk a little more directly into the mic, because you're fading in and out a bit. Thank you.
Okay, Quentin, is that any better? I'm leaning forward. I have an attached mic. I can remove that and see if that's any better. But if this is okay, I'll just continue.
Yeah, okay.
All right. So global health is also a difficult term because it is a term which is not universally agreed upon by everyone. And so my talk will emphasize a particular dimension of global health, which I believe to be particularly pertinent at this time. The third is post-pandemic, and I detect a hint of optimism here. The world certainly seems to be transitioning from a post-pandemic phase to an endemic phase. But what exactly lies ahead, we can't really tell. We are not sure. Many people remain unvaccinated. And so the question is, will future variants come along that will be more transmissible and or more deadly or less? So there remains a lot of uncertainty. So instead of post-pandemic, we could just as easily be referring to intra-pandemic or inter-pandemic. And then finally, around the decolonized mindset, this is a term which we hear about a lot, and I think it raises some very important ideas. But again, there is no agreed understanding of what this term means. It means a lot of things to a lot of people. So, it is therefore bringing it all together with all these uncertainties and lack of clarity is not an easy task for me to talk about. And so what I will do is I will incorporate ideas around all of these terms, but I will subsume them under three questions. The first is, what has been the impact of the COVID-19 pandemic? Secondly, what has the pandemic revealed that can help us strengthen global health as we go forward? And then thirdly, and finally, how might we respond to what we have learned? I think I will keep it fairly short, and I'll probably not use all the time that's been assigned to me, so that we can have more time for discussion and Q&A, because I think the really interesting bits will come from you as an audience rather than from me droning on in this talk. So let's start with the impact of the pandemic. I think we will all agree that COVID-19 poses a once-in-a-lifetime existential threat to people everywhere. The health effects of SARS-CoV-2 have been far-reaching and severe. These include the direct effects of the virus on morbidity and mortality. We know that the total number of COVID-19 infections worldwide is currently estimated at just over 500 million, with about an estimated 6 million that have succumbed to the disease. Now, these figures are likely to be gross underestimates of the true toll of the disease. For example, a paper published a few weeks ago estimated the true number of deaths worldwide to be about 3 times higher than what the official figures would suggest. COVID-19 also affects health through its impact on the health system. In many countries, hospitals have been overwhelmed by the sheer volume of patients presenting for treatment, leading to facilities not being able to keep up with the demand for personnel, for equipment, or for therapeutics. The pandemic has also severely disrupted routine healthcare and other essential services. For example, people suffering from diseases such as HIV, TB, heart attacks, strokes, and cancers have had their care delayed or denied because of resources being redirected to COVID patients. And of course, children requiring vaccination for preventable diseases like measles have in many instances not been able to receive it. These factors further contribute to the overall suffering and death during the current pandemic. Now, I must say a word about mental health, because it is an important aspect of health which has been impacted by COVID-19. For many who have lost loved ones during the pandemic, the grief and sadness have been profound. Others experience stress from worrying about the risk of infection to themselves and their family members. This is particularly the case where vulnerable populations have not yet been able to access vaccines. Furthermore, working from home has become the new normal. But I think we sometimes don't sufficiently recognize the stress that this causes for those who have responsibilities of caring for young children or elderly parents. And on top of all of these stresses, many have had to bear the burden of the loss of income. So collectively, isolation, psychological pain, mental stress have had many knock-on effects, including increases in alcohol abuse, domestic violence, homicide, and suicide. The consequences of the pandemic are, of course, not limited to health. COVID-19 has also caused an unprecedented humanitarian crisis. Coronavirus infection combined with policy measures to mitigate the risk of the disease, such as social distancing and in particular lockdowns, have led to massive unemployment, food insecurity, and disruption of schooling. So the impact has been on multiple levels, and it has left the world reeling. I now come to the second question, which is, what has the pandemic revealed that has relevance to the strengthening of global health as we go forward? Now, I'm sure there are many things that have been revealed, and it is not my intention to present a comprehensive list of observations here. I simply will mention a few that I think have particular pertinence for the future of global health. First, COVID-19 has highlighted the fundamental importance of the social determinants of health. The pandemic has shone a bright light on pre-existing inequalities and vulnerabilities. These inequalities have led to huge differences in the consequences borne by people living under different social and economic circumstances. All over the world, it has been the most vulnerable who have been hit the hardest by the pandemic. These vulnerable groups are those who face systemic exclusion and discrimination, such as the poor, people of color, older people, women, children, people with disabilities, migrants, and refugees. Among these, those living with multiple intersecting vulnerabilities are and will continue to be worst off. Disadvantaged populations have higher COVID-19 infection rates and higher death rates than their more privileged counterparts. This may be due to poor living conditions, such as overcrowding, which makes social distancing difficult, or to poor health, which leads to pre-existing comorbidities. In addition, measures aimed at mitigating the spread of infection with the virus and reducing the burden of COVID-19 on the health system, such as school closures, movement restrictions, business closures, and requirements to work from home, disproportionately affect the most vulnerable. The economic impact of these measures have been severe and will undoubtedly be long-lasting. Now, also important to mention here is the problem of the ongoing digital inequity. Nearly half the world's population still does not enjoy internet connectivity. This means little or no internet access to information on current COVID-19 information, working from home opportunities, distance learning, and access to telemedicine. These are privileges that are enjoyed by the other half. The World Bank has told us that the effects of COVID-19, working in tandem with the impacts of climate change and conflict, are leading to sharp increases in the number of people living in poverty. It has been estimated that the number of people living in extreme poverty would increase by as much as 150 million by 2021. This implies a similar upward trend in global food security, insecurity, and hunger. And a recent UN Sustainable Development Goals report has told us that COVID-19 is reversing decades of progress on poverty, healthcare, and education. COVID-19 has also revealed the weaknesses in our various health systems. For low and middle income countries, especially those in Africa, the chronic shortage of health professionals, especially those trained in critical care, and inadequate tertiary care facilities, as specialized hospitals, for example, equipped with intensive care units, have been brought into sharp focus. It has been noted that many health systems were not well prepared for coping with the pandemic, with a lack of resources and equipment, limited testing ability, and inadequate surge capacity to deal with COVID-19 being among the most noticeable weaknesses. These problems are by no means confined to Africa. The poor performance of health systems in some high-income nations also illustrated the risks of underinvesting in public health systems. That brings me to one of the most egregious shortcomings of the global response to COVID-19, which was the lack of solidarity between nations in the face of a common threat. The most obvious example of this absence of solidarity can be found in the scramble for access to life-saving vaccines, in which rich countries obtain the lion's share of vaccines, often far outstripping what was needed by populations living in the rest of the world and leaving them out in the cold. It is estimated that by November 2021, 75% of vaccines had gone to high and upper middle income countries, leaving only 0.6% of doses which could be administered to low income countries. The COVAX initiative was created as a mechanism for improving vaccine access for people in low income countries, but it remains underfunded and has not been able to deliver on its promise, partly because rich countries focused on entering into bilateral deals with pharmaceutical companies at high prices in order to ensure preferential access to vaccines. But the COVID-19 pandemic has also revealed some good practice examples, particularly from the global South. The example I wish to offer here is that of the Africa Centers for Disease Control. The Africa CDC has been at the forefront of creating and coordinating a continent-wide approach anchored in collaboration and solidarity. Less than 6 weeks after the first confirmed case in Africa, a joint Africa continental strategy on COVID-19 was endorsed. Important initiatives followed, such as the establishment of the Partnership to Accelerate COVID-19 Testing, which enabled African countries to procure more than 90 million test kits and to train thousands of laboratory workers. Another key outcome of the strategy was the Africa Medical Supplies Platform, which focused on the procurement of critical medical supplies, such as ventilators and personal protective equipment. I will now move on to my last question, which is about implications for action to strengthen global health. In this final part of the talk, I would like to briefly reflect on the implications of what we have learned in the pandemic for some measures that can help strengthen global health in the future. Implication one I would like to suggest would be that there is a need to reconceptualize our understanding of global health. The term global health means different things to different people. For people in high-income countries, global health is often seen as public health practiced over there, meaning in poor countries. This is a throwback to the days of tropical medicine and its subsequent reformulation as international health. It is a colonial perspective, and it is not where I believe global health thinking should be. The way forward, in my view, begins with an important conceptual shift. This shift is encompassed by the now well-known definition offered by Copeland and colleagues in the Lancet in 2009. And although this definition has been around and this aspect has been very clear within the definition, I don't believe that it has received the attention that it deserves. So what is the definition, according to Copeland? It is as follows, and I quote, that global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. This definition is important because I think it reminds us that the poor and vulnerable can be found everywhere, that is, worldwide. And I think if we grasp this and it becomes part of what we understand global health practice to be, I think it begins to change the stereotype of global health always being about people from the rich world descending upon low and middle income countries as saviors to rescue the poor and dying. What we have learned about the plight of disadvantaged groups in the COVID-19 pandemic is that they can be found everywhere. And so I think this should be something to motivate us all to unite and to work together as partners in a global movement to advance health equity globally. Structures that cause illness and suffering for some and not for others can be found in most places around the world. Such structures may include financial constraints, poor service delivery, inadequate physical infrastructure, underdeveloped knowledge infrastructure, historical and socio-cultural factors, geographical and environmental limitations, and of course, human resource limitations. These factors often require to be addressed, require partnerships that are transdisciplinary, intersectoral, and collaborative. These partnerships can be local, national, regional, or global. And so this brings me to implication 2 of our observation, which is that we need to continue to build healthcare and scientific capacity everywhere. We have seen how COVID-19 revealed the fault lines in health systems worldwide. Some resilient health systems have responded rapidly and effectively to the pandemic, while many have not. Needless to say, COVID-19 is not over yet, but it will also not be the last pandemic we face. We will continue to be challenged with global and local events related to new infectious diseases, climate change, conflict, and the increasing burden of non-communicable diseases. There is therefore an urgent need to address the shortcomings in our health systems to achieve better care for our populations, including ensuring the capacity to provide treatment for critically ill patients. These efforts need to go beyond providing physical infrastructure and healthcare worker training. Universal healthcare, as called for in the United Nations Sustainable Development Goals, must become a reality. It should include access to primary healthcare services that is integrated with social protection systems and community-based social care, always giving greater attention to prioritizing the needs of the most vulnerable. I referred previously to the digital divide. Bridging that divide and creating digital equity will support better collaboration among stakeholders in delivering comprehensive healthcare and social protection responses. Our goal should be to build health systems that are able to respond to all health challenges at all times and for all people. Global health is about leaving no one behind. As Martin Luther King Jr. once said, quote, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Health and healthcare are fundamental human rights. They are matters of social justice. Neglecting these responsibilities not only leads to avoidable suffering, but also decreases trust in our institutions and political leaders, which negatively impact on our societies as a whole." But more than health care delivery capacity, our experience of COVID-19 should also be a motivating factor for us to increase investments in science, technology, and innovation. Earlier, I mentioned the problem of vaccine inequity, which arose during the pandemic. This was a wake-up call. It has spurred low and middle income countries to take more decisive action to build their own capacity for coping with future crises. Some African countries are already collaborating within the continent and beyond in an effort to build capacity for vaccine development and vaccination rollout. For example, in South Africa, a number of public and private sector partners are collaborating to develop and build a global mRNA vaccine technology transfer hub. This will be replicated in a few other African countries under the aegis of the World Health Organization. At the recent Cape Town launch of the new facility, Dr. Moeti, Regional Director of the World Health Organization Regional Office for Africa, said as follows: "The mRNA hubs provide an unprecedented opportunity for capacity development, putting Africa on the path to self-reliance. This initiative will enable the continent to better protect against outbreaks, control the COVID-19 pandemic, and develop new vaccines, accelerating the elimination of dreaded diseases such as HIV, malaria, and tuberculosis. We are opening the door," he says, "to better health and well-being for our people." In addition, the Center for Epidemic Response and Innovation has recently also been established in South Africa. This is how we begin to reimagine global health as a truly global enterprise. The third and last implication I will mention today is, I think our observations to date should encourage us to do a better job at holding our leaders to account. It strikes me that most governments are rather keen to sign on to global declarations, treaties, and commitments, such as the previous UN Declaration of Human Rights or the more recent United Nations SDGs. However, only a few of these follow through on those pledges in a sustainable manner. We need to hold our governments to account to ensure their commitment. Taking people out of vulnerable situations is possible, but for this to happen, we need committed leadership and collaboration. People's lives can be transformed by providing access to public services such as health, education, transportation, clean water, and sanitation. Governments cannot, however, achieve everything by themselves. And this is why we need partnerships between government and civil society. And we need to ensure that communities and marginalized populations have a key role in decision making. Finally, let me say a word about foreign aid. Many countries, I believe, are still too dependent on foreign aid from the global north to keep essential services afloat. This is counterproductive as it undermines agency. It also absolves governments of responsibility for their own citizens. Is it too much to ask of governments to take responsibility for providing basic commodities and services, such as the items on the WHO essential drug list, or routine childhood vaccines, or bed nets for malaria, or child health services? Should there not be a clear commitment to progressively realize this goal over time and weaning themselves off foreign aid? In the same vein, one could mention the ongoing dependency on technical assistance paid for by the global north. How long will this continue unabated? Would the funds not be better used to build local expertise or to use local expertise, and where such expertise does not exist, to build technical capacity? These are the thoughts that I would like to leave with you as I close. And perhaps just one more quote, which I think is also very thought-provoking to end off with. And this is a quote from Arundhati Roy, the great Indian author, who recently wrote, "Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks, and our dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly with little baggage, ready to imagine another world and ready to fight for it." Thank you.
Thank you very much, Dr. Volmink. That was a fantastic talk. And thank you for sparing the time this afternoon to share that with us. I think we can all recognize some of your reflections there and appreciate your trying to get in all the concepts that were in the title there, including the decolonizing element. Now we've got a few minutes, I think round about 20 minutes for questions, and I can see a few coming in already. But I just wanted to sort of push you a little bit, maybe on the decolonizing side of things, and Professor Eichbaum has also touched on this. I can see it in the chat. I was actually in Stellenbosch last week, talking to a group of young African researchers about the topic of decolonizing global health. And we were discussing the sort of ways to approach that. And I think towards the end, when you're talking about the need to wean, governments need to wean off, off global aid, and using funds to build local expertise, sort of touched on perhaps the way you might see approaching this. But I think in the global north, we've been talking about sort of the low-hanging fruit in a way. How can we start to decolonize by changing some of the elements of our partnerships, or the sort of baby steps in a way, whereas some of the writers who've been writing a lot about global health, Shea Abimbola and Madhukar Pai, have been suggesting more radical a shake-up of things, in that they're suggesting that if we sort of continue in a way that's set in colonized structures of the past, we're stuck in that pipeline. So what we really need to do is raise global health to the ground and start again as an entirely sort of new model based on, as you rightly said, the idea that inequity is global. It's not just a problem of those countries over there. So what's your take? Are you for the sort of the baby steps, or are you more of a radical rethink approach?
Thank you, Ray. I think that the decolonization process is multifaceted, and it has many layers, and I think it happens at different places. I think ultimately it is about inequalities of power, and it's trying to redress that power imbalance. And I think part of it is trying to understand, the codependency that has come about within global health, that both developed or so-called developed countries, high-income countries, if you like, they need to ensure, for example, that flow of funds to support themselves working elsewhere, and so they have no interest or little interest in changing that model because it works for them. But it maintains the colonial relationship, which is to say that it is the people with the money, the people in high-income countries, who, because they have the money, call the shots and determine which way things are going to be, even determine which knowledges are to be privileged, for example. And so it's a wholesale transfer of not only Western ideas and Western thinking, and disadvantaging local knowledge, or pushing that to the back, but also, so I think that's one aspect of it. I think it is also determining how problems will be solved at a local and regional level. And so I think all of those things need to be challenged. And I do think, it's easy to speak about being radical about it. I think it should be a process. I think it should be there should be agreement that we all need to move in a particular direction. For example, it's impossible to overnight abandon all foreign aid. But you can have an arrangement that you say by the year 2030 or 2040, this is what we would like to progressively have achieved. And so I am for change, which is progressive over time rather than everything happening tomorrow.
Thank you. That was very clear. All right, there's quite a few comments in the chat already, and people do. If you would like to speak your question in person to Professor Volmink, please put up your electronic hand. Otherwise, type it into the chat. Dr. Keith Martin, Executive Director of CUGH, you had a few points you wanted to ask Professor Volmink. Do you want to speak them out?
Thank you, Zoe, very much. But first, I'd like to thank Professor Volmink. It's wonderful to see you, Jimmy. And from all of us at CUGH, thank you so much for sharing your views with us. I just wanted to know if you could share with us, as a point on inequities, you do inspiring work at CUGH. And the inequities there, obviously, is, as we all know, was rooted in the apartheid regime. Could you share with us the inspiring work that you're doing in CUGH? And it leads to the role that academic institutions can do to address the social determinants of health inequities that are right in their backyard. Could you share with us how academic institutions can play a much more active role in dealing with those inequities that are right next to them? And please share, if you can, if you feel comfortable, the really inspiring work you're doing in CUGH. Thank you, and I hope to see you in Cape Town later this year.
Thank you, Keith. So, I'll just simply say that a few years ago, I happened upon a group of young people who really impressed me. They all came from the most deprived part of CUGH, the most disadvantaged part of CUGH. They were living in shacks. They did not have many adults in their lives. They were often living alone or being looked after by older siblings. They had difficulty with schooling. They had no running water, sanitation, etc. I decided to follow them home to CUGH. And for the first couple of weeks, we sat and looked at each other and didn't say much. But soon we started relaxing, and I started learning about their lives. And I think this is so important that somebody has said, I think it's somebody working in the prisons community in the US, that to make a difference, you have to have proximity to the problem. You have to change the narrative, and you have to have hope. And I think those three things are really very important. I learned that by showing up and talking to these young people, they soon started opening up about their vision, their dreams for the future. We started bringing in some students from Stellenbosch to tutor them. We've seen over the years some of them going, finding out about university, going to university, even completing university, and going into employment, and moving out of some of them moving out of CUGH. So seeing the whole transition from the squalor in which people have moved, and with support, how people can have their lives change and how they can become more productive members of society, was certainly something which I don't take credit for, but I'm so pleased that I was a part of and continue to be a part of. So Keith, I think that's really what you're referring to, and I won't speak too long about that, just to mention that it is still going on.
Thank you for that. Peter Kilmark, you've put us questions in the chat. Do you want to read it out for Professor Volmink?
Sure, thanks, Zoe. I can do that. And first, just wanted to congratulate you, Professor Volmink, on really an outstanding talk. My question was about the element of trust between the high-income country and lower and middle-income country global health workers, just interpersonal trust. And from I'm going to present some findings from a survey in our breakout session coming up, but it seems like that's a very important factor. And I'm wondering what your views are on what the effect of the COVID-19 pandemic has been on that trust, obviously at the sort of national level and the vaccine issues you've touched on, but I think there's also been a lot of impact at the individual level. So I'm just wondering what you think the impact has been, and then how that trust can be either strengthened or restored.
I think that trust is certainly absolutely essential for successful partnerships. And I think where those partnerships have survived COVID-19 and have continued, I think they've tended to be largely collaborative, supportive, and I think overall probably been strengthened as a result of this mutual crisis, this crisis faced by everyone. I think that the crisis has also built a sense of self-esteem on the part of those in difficult circumstances, let me put it that way. That they, despite all the disadvantages, they could, we can do a lot. There's a lot we can do with or without our partners. We would prefer to work with partners in a collaborative way, because I think there's a lot that we can learn from each other. And I think as long as those partnerships also, are based on a sense of equality and not coloniality, I think trust will continue to increase.
Positive message. Thank you for that. Dr. Chega, over to you. How are you?
Oh, hi. Thank you so much, Zoe. Sorry. Hi, Jimmy. It's great to see you. And hello, everyone. Jimmy, I have a quick question. And you've been one of the key player when we were writing the MEPI grant at Stellenbosch. So my quick question is, in that reflection of decolonizing global health, the funding mechanism from the north to the south, I think MEPI was catalyzing to change, to start the small step to change that by allowing institution in Africa to be the prime recipient of major grants, and today AFREhealth on this path is making progress with the recent Africa CDC major grant they just received. Could you speak to that also, the mechanism, the funding mechanism between the North and the South as in our work in global health?
So I thank you for mentioning MEPI. This is the Medical Education Partnerships Initiative, Jean, and which you were a PI. And I think that it's such a good example of a grant led by the Global South, which has been used to build capacity in Africa. I think that there is a slew of positive outcomes in terms of the MEPI grant that we had at Stellenbosch, for example. As you know, it was largely used to build healthcare and health training capacity in rural areas. And the fruits of that continue way into the future. I think it raises an important issue about research grants in general. This was not a research grant specifically, but I think that the trend towards ensuring that part of a research grant goes to building capacity, research capacity in low and middle income countries is a very important trend. And I think that needs, in my view, be built into grants that we receive from anywhere, whether that be local or international.
Thank you.
Thank you. Yes, Jimmy, I totally agree with that. Judy Kanyola, you had a question. Please go ahead.
For this really inspiring talk, sir. I was part of the NEPI, which was a follow-on of MEPI, and this was now the Nursing Education Partnership. And by that, I guess you can guess I am a nurse and midwife. I would like to ask you a question around intersectionality. I find that, yes, the North-South divide is there and things are being done, but what would you say around, for example, we can be working so hard to decolonize various partnerships like we are discussing this afternoon, and we forget that we ourselves perpetrate other inequities within ourselves, within our institutions, within our professions. What would you say around that, so that it isn't like a one size fits all, if I could say that, but more around I'm working hard to decolonize, but me, myself, I practice or perpetrate other inequalities like gender, for example, or often with our professions, we have, I would speak about the doctor, nurse, interprofessional inequities that are rife there, even in Africa today. Thank you, over.
Yeah. Thank you, Judy, for that important question. And I do think you're absolutely right that decolonization, as important as it is really only one aspect of inequality or inequity that we need to focus on. And I tried in my talk to mention other dimensions and how they intersect with each other, as you point out. So I think that briefly, I talked about exclusion and groups that are excluded from participation. I feel that when we exclude certain groups, we are all impoverished. And so in global health, because we are driving an agenda of equity, we should be looking at all the domains in which we could have inequity. And I think that we begin, there's three things that I think are important. One is to always keep in mind the importance of diversity in what we do. I think, let's see, we're living in a country where there are men and women, there are different ethnic groups, there are other people, and not all of them are equally included usually. So let's strive to include them and be diverse. So diversity leading to inclusivity, which I think you can have diversity without inclusivity, but inclusivity really means the opportunity to be an active participant and to have their voice heard. And then I think ultimately we're looking at belonging, where in a team, for example, we need to be sure that not only do we have diversity and inclusivity, but that everybody feels that they really truly belong in that team and can make a contribution. So I can only agree with you that looking at all these dimensions of inequality are really important.
Thank you very much. Rana, you have a question. It was really, I guess, an additional comment to that. But Gurpreet is a librarian, and she's asking how we better accomplish interdisciplinary collaboration with consideration to professions that are not traditionally considered involved in global health. Just got a quick comment on that. I'm just aware we've only got a few more minutes left, and there's lots of questions coming in now. So perhaps if you could briefly address that one, we'll try and squeeze a few more in. Thanks.
Yeah. Interdisciplinarity, very important. Getting different disciplines involved. I think it's how we structure our research questions. I do think that to begin with, if we structure it in a way which invites participation, from people from different disciplinary backgrounds. That will help. I think another useful aid to promoting interdisciplinarity is incentivizing. So, you know, if you have a grant which incentivizes people from different disciplines bringing to bear their knowledges and their thoughts and skills on solving the problem, I think you will automatically have a lot more people from different disciplines working together. How that is managed is also important. And I think I don't have too much time to talk about that, but when I've worked in interdisciplinary teams, you know, tensions do arise because of our different ways of seeing issues. And I think that needs to be recognized, acknowledged, and managed as we go forward.
Great practical suggestion there. Thank you. So David Muganza, you had a question, and then we'll leave the last word to Quentin, if that's all right. David, over to you.
All right. Thank you very much. I'm David Jolly. I'm a part of the AFREhealth student community. So to Professor, recently I was going through work by Ray Dalio, and from his analysis, this inequity between the North and the South is caused mainly by the creation of value. There is less value being created by people in the South, or in Africa, I should say. And as you've mentioned, the COVID-19 situation showed us that that this is actually evident because we had less people creating solutions for the whole situation, including the vaccines. And we see that this is a little bit perpetuated by the systems of training through our education, in that our education is being more cultural and less progressive to create value with the outcoming technologies or outcoming things like artificial intelligence. And so my question to you is, what do you say about the whole concept of the South creating less value, and this perpetuates the inequity because then there is less monies that flow, that are made, and then we have the inequity between the global South and the global North. Thank you.
I would simply say, who decides on what the value is? Because on all teams that I've worked on, international teams, I think the people in low and middle income countries have been critical to the success of the projects. So I'm not sure that I buy the notion that there's more value coming from the North than from the South.
Yeah, I think that's, again, it's perpetuating maybe that coloniality, that the only voices that really matter or really have any quality are those coming from the North, and it's up to all of us really, in the North and South, to disrupt that, and you know, not really make our voices heard, I think, and our value known. Quentin, so last question is yours. Over to you.
Thank you, and thanks, Jimmy, so much for this great talk. So maybe it's good that this question comes at the end, and following on Judy, with whom I conducted a webinar some months ago, mostly for the students in global health. And I want to ask you, there's a fairly high level of concern and almost anxiety about many students in the global North who've planned careers in what we still call global health. And they're wondering, you know, is this still a career for them? What do they do where there's so much about decolonization? Are they out of the picture? Is this something they should still be doing? Or are we, as I put in the chat earlier, are we really talking about the obliteration of global health? And I take your point that it's a slow and iterative process, but what would you say, in short, to a student most in the global north, planning a career in global health today?
I'd say come back home if they are from low and middle income countries, because I think that sometimes I speak as someone that has lived overseas in the US and the UK, and I felt at times that I might want to stay there, but what drove me home was the knowledge that I can really have an impact, of greater impact here, because of the skills that I have and that I can share with others. I think that I guess the concern, Quentin, is that there's a lot of criticism of global health. To be honest, I don't, maybe it should be, the name should be changed to global health equity, but I think that equity is the key. And I think inequity will be with us for the rest of our lives. So there will always be inequity, both in high-income countries and in the rest of the world. And where there is inequity, there will be something for us to do if we're working in global health.
Yep, that's a fantastic way to end this this talk. I think you're totally right. I mean, it's inequity exists in the north and the south, and if students of global health are taking on a degree, and a large part of that degree involves having some kind of exotic experience in a low middle income country, I think that they will definitely have to rethink that, because if you want to practice global health, you can be practicing it in the UK. We have poverty, we have all sorts of health inequalities in the UK and in the US. So, students are going to have to rethink what global health means. We're all going to. So, so I'll wrap it up there and say thank you so much, Professor Volmink, for spending an afternoon with us. If everyone would like to turn their cameras on, maybe, and put your hands together, we'll say thank you very much for sparing the time. Thank you so much.
Thank you, Zoe. Thank you, everyone. Thank you.
Thank you so much, and thank you, Zoe, for facilitating the session so well. It's very well done and very memorable session. Thank you so much. Very much to think about here, so we really appreciate it. And I'm going to follow up with you after this on how to put these thoughts out. There have been some requests, and maybe we can put this forward in a joint article. But thank you so much. So we're going to move ahead on the agenda, and everyone, please stay engaged. The next part is very brief report backs from the subcommittees. And I say that in the context that we have had 2 years of pandemic, which have interrupted much of the activities we would have otherwise had in person. It's not always been easy to sustain the working of these subcommittees, but that's why we're just having a brief report back. So I'm just going to call on either or both of the co-chairs of each of the subcommittees to tell us what they have been doing over the past year. So the first one is research, and there's Jean and Peter. I don't know, either or both of you. Is Jean still on the talk? Otherwise, Peter, I think you were both involved in the research subcommittee, and I know you have been active.
Yeah, Jean is going to go ahead.
Jean, are you still there? Just a few minutes. Jean, you're muted, or are you still there? Your name is still there.
Can you hear me?
Yeah.
Okay. So yeah, just briefly. So during, I'm gonna just give you highlights of activity between AFREhealth and CUGH under research. I chair the AFREhealth Research Committee, and Peter is co-chair of the CUGH Research Committee. So over the last year or so, I think the few important highlights is that AFREhealth and CUGH member have been able to collaborate successfully on multi-country COVID research study focusing on vulnerable population, especially pregnant women, children, and adolescents in Africa. So we will give some results in the small group just on that. Also, what has been successful also with high demand was AFREhealth CUGH sponsored scientific writing, which focus only on young investigator on the African continent, especially those who are Francophone speaking, Lusophone, but also those actually who speak English, but need more training. So I will give some output for what has been rewarding and seeing first auto publication from selected trainees. Also, I want just also to mention another milestone, which is the contribution to the AFREhealth contribution to the CUGH abstract mentoring program, and also selected contribution of AFREhealth on specific conference, the interests, the essence, and also the recent Africa CDC African Union conference on public health in Africa. Thank you. Back to Peter.
Yep. Thanks, Sean. Quentin, I'm just going to add a little bit. First is to say how much I've appreciated working with Jean and the AFREhealth leadership, and how impressed I've been at the webinars that they've also had on COVID-19 and their multi-country collaborative research. So I co-chair the CUGH Research Committee with Judy Wasserheit from the University of Washington. We have over 20 members, many from North America, but also from all over the world, and very active engagement with the CUGH Trainee Advisory Committee. Jean mentioned the Abstract Advising Program, which we support. There were nearly 60 advisors and advisees that paired together to improve the advisees' abstract before submitting to this conference. And we really did have very strong support and engagement from AFREhealth and African representation as advisors and advisees. In our CUGH working group, our main areas have been around climate change and health, and very strong engagement with COP26 in Glasgow last year. And critically, COP27 will be in Africa this year in November in Egypt. And so we look forward to good engagement with AFREhealth in our working groups work on climate change and health. We also have a working group on addressing the anti-science movement, and want to note that we have a research committee satellite session coming up on Thursday with speakers including Peter Hotez and Heidi Larson and John Dictakenema from the DR Congo. So John and I just want to encourage people to join our breakout session. As he mentioned, John's going to talk about COVID-19 research and the unfinished agenda in Africa. I'm going to talk about using metrics to help make our capacity building more equitable and effective and building research capacity. And then also talk about the recent survey we had on decolonizing global health with input from CUGH and AFREhealth leaders. So thanks, that's it from the research committee. We look forward to the other updates and hope folks can join us in our breakout.
Thank you, Peter. So the next one on the list as we go down was the education subcommittee, and we will not talk about the education committee of CUGH, which is a very big committee, but we could also, as time, give some of the activities. But Judy Caniola and I co-chaired that, and I'll let Judy go first, and then I'll add in what else. Judy, did you want to speak first?
Thank you, Quentin. The education subcommittee, as Quentin has alluded to, didn't do much, particularly just because of COVID. But last year, we were fortunate to, this time last year, the same panel, we talked about virtual learning platforms, and we had three really interesting presentations from folks in the global north who are dealing with various types of learning technology, Lecturio, ScholarX. And we had a very interesting one from the University of Turku in Finland, which was looking at an e-teacher course, which was really supporting the development of teachers to teach online. So following that, we were able to form a collaboration with the University of Turku in Finland, and they're working with us to develop what they call an e-teacher course that they're going to do in Rwanda here, starting at my university, focusing on teaching the nursing and midwifery teachers to support them to teach online. So it isn't about the medical or the nursing content, but more around the mechanics of how to teach virtually, particularly in our setting here in Africa, where connectivity is often a challenge. So that has been a really great outcome from the collaboration we've had with CUGH. Quentin has really been supportive around just making sure we were able to meet and talk, and that has gone very well, I must say. And we're going to do it in 6 schools of nursing and midwifery in Rwanda, and roll it out actually to other countries in Zambia, in Namibia, in Tanzania, and also Uganda for a start from April this year for the next 1 year. I would just like to say as well that we've moved towards academic and research partnerships through this collaboration of the ACWG. And so we are not just, it wasn't just about the e-teacher, but really now moving to work more collaboratively and include more countries. So like I mentioned, Tanzania, Namibia, Zambia, Uganda, and Rwanda are part of this initiative that we are having with the University of Turku in Finland and ministries of health in the said countries to move this forward. And all of this as a result of the ACWG working group. In addition, I think like Peter, my colleague, has said before me with the research, and Jean as well, committee, we've also been able to be part of some of the decolonization work that CUGH is sort of fronting, which has really been good to see. And that has sort of, I want to almost say, taken a life of its own around decolonizing and having these discussions, which are very intentional, very good, that really allow us to shine the torch on ourselves. So I think in addition, I would just like to mention that. And for us here in Africa, we're actually moving forward to go into a series of webinars that's just looking at the setup of colonialism in Africa and just going back to historical narratives and really planning to have a really bang up job around that. And so look to that, it's coming through. I think, Keith, you might be in the picture around that, where we are looking to have this decolonization seminar series of webinars in Africa. So all of that as a result of the ACWG. Thank you, and back to you, Quentin.
Thank you, Judy. And I think the point you raise is an important one. There should be and has been more collaboration between the 3 subcommittees. And I think you alluded briefly to the webinar that you and I ran with the TAC, the Training Advisory Committee, and I think GEMAX very much involved in that, which was very well attended. Several hundred people attended that on decolonizing global health for students, which just went to show that there's a lot of interest and concern, I would say, as well, about global health and where that field is going. So that was a very successful webinar, and CUGH with AFREhealth is planning another big series. Following on what you said about the Turku group, they did an excellent job as well for the consortium of new sub-Saharan African medical schools, which is actually showing people how to develop virtual platforms. And I'm very glad that they did interact with you in Rwanda, and they have in other countries. So if anyone's interested in following on their course, they've been developing this course for 20 years, please let us know. The other people who spoke last year were Lecturio and ScholarX, and Lecturio has got an incredible platform, and they're actually this year having an entire satellite, either as we speak or tomorrow. So these are activities. There is also the education subcommittee at CUGH that has a lot of subcommittees, and I think I saw James Hudspeth still on the call here. Anyone interested in finding out more from that subcommittee, definitely contact James and Tracy. James, I don't know if you want to comment for a few minutes. I don't want to put you on the spot, but.
Thanks, Quinn. Yeah, I think, sorry, and I'm just in transit, so I have to be off video. I don't think anything too huge to add there, Quentin. I think Roy and Etienne have been heading up the Educational Product Subcommittee for the Education Committee, and I think very much re-envisioning it to be focused on AFREhealth and on sort of faculty and trainee needs, like trying to build products that are specific to what the AFREhealth members might want. So I think we're still a little bit in the planning stages of that. We're building out membership, and as you pointed out, we'd love to have more people joining that subcommittee to help provide the humans needed to produce the products. But I'm hopeful in the next few months that will shift a bit more into production. I know Roy and Etienne have been thinking a lot about what exactly the needs members are, and doing some discussion and surveys as well.
Okay, thank you, Jane. Thank you. So last but definitely not least are the student exchanges group. I think I saw Faith Nawaji still on the group. They've always been very active. Faith, are you there? Would you like to comment?
Sure. I'm here. And sorry, I won't switch on my video because I'm on a low bandwidth network. So I would prefer to be on audio. So colleagues, in the past 1 year, we resolved that it's important that students from both CUGH side and AFREhealth side are able to attend some of these initiatives and also work together collaboratively so that they can work together to innovate as students, as future health workforce and all that. But the challenge with that is that AFREhealth didn't have an AFREhealth student community, but I'm happy to report that in the last 1 year, an AFREhealth student community has been developed. And there is a leader, he's called David Muganzi, and he'll be able to say some little words about himself and the group he's working with and what a few of their plans are. So that is one achievement that we had to ensure that the students also are really part of this. Beyond that, last year, we did not have CUGH AFREhealth exchanges because of COVID-19. However, on the AFREhealth end, we were able to innovate and develop virtual interprofessional education electives. This was first piloted last year, and it's continuing to be implemented this year with 13 training institutions in 10 African countries, with 27 faculty participation from different disciplines and using country-specific case studies to guide the learning. And each of the students had to take this elective placement virtually for 6 weeks, utilizing Zoom as a medium for synchronous learning. Of course, other ways of asynchronous learning. So pretty much that is what has happened. And today we look forward to TAC linking up with the AFREhealth student community so that they can now pave a way forward to work together. I don't know if David is on the call. He can just give a little update about the student community of AFREhealth.
David, are you on the call? Oh, there we go. Just a few minutes on time. Is that David Muganzi you're talking about?
I'm on. Thank you very much, Faith. Muganzi individually, as she has introduced me, and I'm a final year medical student in Uganda, and I'm leading a team of 11 students who have been working on setting up the AFREhealth students community, and the students are coming from different parts of the continent. We have a work plan, a 5-year strategic work plan where we are working on basically 4 objectives. And inside there, we have 11 outputs. And our first objective is to facilitate enhancement of health professional education in Africa. And the second is to educate and cultivate a culture of research and health professional students, and also encourage evidence-based practice. And lastly, we are working to connect health professional students across the continent. And in this regard, we shall be launching very soon. We shall make an official launch of our community and also share ways in how to collaborate with students from the CUGH side. And I think basically that is what I can say about what we're doing. Thank you.
Thank you, David. I think there's some background noise coming from Kwani's mic. There we go. So those are the committees have been variably active. Mostly the pandemic was interrupted some of the activities, but we will now have a lot of time to go into breakout rooms, and I encourage everyone to participate in those. There are 3, there's research, student exchanges, and education. And the idea there is to plot a path forward and to consider what the next step should be as we go forward, and perhaps also have more opportunity to meet in person at the AFREhealth meeting in Zimbabwe this year. So I think you can choose the group you want to join. You may be able even to switch between groups, I'm not sure. But could I ask the CUGH people to make the groups, breakout rooms available for us so people can decide how to join them? Thank you for managing that on time, and I'm glad we had more time this year to talk about. We always run out of time, even if we give people an hour to speak. But I hope those were fruitful discussions. I think we are now at a point where we've want to give each group some time, 5 minutes or 5 to 7 minutes. We have a total of about 20 minutes for the breakout groups, probably 15 at this stage, to report back on what they discussed. So I'll keep 5 minutes each. I'm going to watch the time because we want to have some time at the end to summarize. So first on the list again is the research committee. Either Peter or Jean, did you want to report back on what you talked about and how you see your path forward for the coming year?
Yeah, thanks, Quentin. Jean elected me to report out for the group, so I'm happy to do that. We had about a dozen people in a nice mix of geography and backgrounds and genders and everything else. So we had a nice discussion in our group. We went through a few topic areas. First, Jean presented some of the work that he's been doing with AFREhealth and multi-country research on COVID-19 in children and in pregnant women, and briefly presented the results of that, the publications from that, some of the impact, a lot of the lay press that's picked up on that work. And then the discussion was about some of the methods and the challenges of conducting that kind of multi-country research using the clinical data, and then talked about some of the future research directions. Definitely a strong consensus that that kind of multi-country work is important and should continue. Vaccine hesitancy was one of the key areas for future work for what Jean's doing, but it's really impressive and was well received by the group. One of the other issues was about whether there were differences in outcomes based on Francophone versus Anglophone countries, and it was really more around just the level of care, the quality of care, and so somewhat worse outcomes, lower ICU access in the DRC in West Africa than in the countries in East Africa and South Africa that participated. So then we moved on. I gave a short presentation about some work we're doing, developing metrics of national health research capacity, looking at the numbers of publications and clinical trials, and using that to try to be more equitable and effective in our research capacity building efforts. And we actually have a map of the world and looking at some of the countries that have quite strong research capacity, even sort of above and beyond what you would expect based on their GDP or either overall or their per capita income, and potential for using those as case studies about how to build a strong research capacity even with a weaker economy, but that we could use those kinds of metrics to direct our capacity building efforts and try to find out what the issues are in the lower research capacity countries to help them to improve their capacity, largely to address their own health research issues, but also in the event of an outbreak that we'd be able to conduct clinical trials. So that there was also endorsement interest in that work. And then we as time was running short, we talked about the findings that I mentioned from the CUGH and AFREhealth survey on decolonizing global health. And with just a few minutes left of discussion, talked about there was interest that potentially that could be published or should be further work on that, and just a bit of time for discussing how sort of overall colonialism and how that relates to global health colonialism, and what some of the differences might be, what Jean's unique experiences were as he's bridging Anglophone, Francophone, low income, middle income, and high income country settings, but also a strong endorsement that that area of work is important and should continue, and that these kinds of surveys of thought leaders on how to decolonize was deemed to be important. So thanks to all who participated. John, I don't know if you have something to add to that, but we had a great discussion and appreciated the time to have that meeting.
No, thank you, Peter. I think you did a great summary. Quentin, back to you.
Thank you. So the Education Committee had, I think we beat you, Peter, we had 16. Just kidding. People came and went, but I'm going to let Judy summarize the report back on our discussion.
Thank you, Quentin. We had, I think, about 11 or 12 people in our little small group, and really had very good discussions around what I think I would just summarize to say decolonizing academic partnerships, and a lot of discussion around the experience, for example, of when students from the high-income countries come to do internships or global experiences, or whatever they would call it in Africa. They operate in a sea of ignorance, and we were looking at exploring how can we change this and have meaningful collaborations around when students come from the high-income countries to the low-income countries. We also touched on medical students operating in ignorance because of this, and what are some of the identifying colonizing inequitable conditions, because we don't know that we perpetrate this, we pass this on to our students. So how can we intentionally now identify these, looking at what we're calling a structural oppression? Do our students know even what colonizing means? So all of these discussions around that were had, and we've sort of agreed by and large to focus on academic partnerships around memoranda of understanding or guidelines around that, looking at specific areas where we can now intentionally break this divide that we have. For example, things around funding, access to libraries, for example, research, using of the technology, like, for example, can we do grand rounds online? when we develop MOUs, how do we look at it from both sides? What are the also shortfalls that also come from the LMICs themselves in terms of these academic partnerships? So I think in summary, we are looking towards having a webinar around academic partnerships. There was also an issue around language and making sure we use sensitive and accurate language. What is that? How do we say that? And how do we teach our students? So broadly, I hope I've done justice to that summary of our very, very interesting discussions this afternoon. Over to you, Quentin.
Thank you, Judy. I think the issue, just to add to that, and this came up on the decolonization subcommittee at CUGH, is what seems to get in the way in a lot of these exchanges, educational exchanges, or the constraints put on exchanges at high-income countries where the education bodies dictate what students have to learn or what they may or may not do. And so a lot of that does go into the MOU, or the program letter of agreement. And I think there may be scope to explore this in the open, possibly through a webinar. What are MOUs about? How are they calling the shots and constraining a decolonized educational process? So I think that I would just add to that. And Mary White raised the point about flipping education on its head a little bit about ignorance. And maybe that's an interesting thing to look at. Where is the ignorance, maybe on both sides, about reaching an understanding across this divide, and what do people really know about, if we talk about colonization, or don't know, and what do we need to know? So I think that was another theme that came across, but we hope to continue to explore these themes on webinars and in our meetings and live at the AFREhealth meeting in August. Thank you, Judy. You summarized it all very well. I just wanted to emphasize 2 points. So we will have an open discussion, but it's now the turn of the student exchanges, and Faith Mawaji.
Sure, I will give an update. Sorry, once again, I won't put on my video for clarity issues due to low bandwidth that I'm connected on currently. So yeah, we had, actually, our discussion was pretty brief. We resolved that we would reach out to the CUGH leadership to link the AFREhealth student community to the trainee advisory committee of the CUGH side, because we didn't have anyone from CUGH or TAC that attended that breakout. We were largely all of us from the AFREhealth end. So that is one of the reasons that we came up with, so that the two bodies can jointly brainstorm and work together on different initiatives like webinars and all that. We also resolved that since this kind of collaboration between TAC and AFREhealth student community is one that is going to be advanced, it would be good for them to have mentorship sessions from both sides that are jointly implemented on various topics and all that. We also thought, lastly, that the virtual initiative that has been developed in the spirit of exchanging knowledge from all over different parts of the world should continue, and virtual engagements between AFREhealth students and CUGH students should be orchestrated and continued. Yes, those were our 3 results, and thank you so much.
Thank you, Faith. Thank you. So the last, we've now got 15 minutes of the discussion, and we'll facilitate a discussion. Georgina and myself just open this up for discussion on the floor, cross-pollination between different groups, ideas. What is this group about? What should it be about? I would like to just open the discussion. We've heard a lot of ideas from the different subgroups that are I think it's always good after report backs to allow time for people to reflect on what they've heard and what they heard from other groups and how we might interact and work forward as a group. As I said in the beginning, this group has been in existence for 5 years now and interrupted in part by the pandemic, but there's a lot of scope and we hope to keep working very closely together into the future. I'll stop there and let anyone comment at this point.
Can I just toss in here one piece of the conversation I think we missed today is humanitarian assistance, medical aid. I noted that there were 3 medical workers from MSF that were basically murdered in Ethiopia the other day. We've got, you know, what appears to be World War III on our hands now. There are new issues here, really pressing ones, if we can throw that in the mix somewhere at CUGH, because this is where many of our people go.
Yeah. It's a tricky issue. There used to be a group called the Global Health Council, was it, that worked most with NGOs. CUGH is university-based. AFREhealth is probably a little less so, but we are both very much university-based. But is our function humanitarian aid per se? But certainly we interject into that domain as well, whether it's you know, social justice, human rights, legal issues. But what do others think? Peter.
Thanks, Quentin. This is sort of an adjacent issue, but we have at Fogarty been interested in conducting research, health research in humanitarian crises, and had a series of workshops and publications about that over the last couple of years, including a presentation at the CUGH meeting recently. And so this is, you know, and we work with MSF and others as part of this. So it's not directly getting to the issues that Mary's raised, but it's clearly, you know, it always has been an issue, but with now the situation in Ukraine and with climate change and other humanitarian emergencies, the importance of conducting health research and learning how to, you know, position protocols, the issues about consent and ethical approval have been really important and of interest to us at Fogarty. Thanks.
Thank you. Yeah, thank you for that. I may have misunderstood Mary's question that we become human aid workers, but more there are a lot of surrounding issues to that, research and equity and all of that. Yeah. Other contributions, thoughts?
Just to say, MSF is a leader in this kind of research already. There's a lot to be learned from them.
Yeah.
All right. Quentin, taking the discussion forward, since we are getting to the end of our session, it's very important that we are able to really look at how we are taking the discussions forward in our various organizations and as individuals, so that it doesn't become a talk shop. I was part of a side meeting and I had my children participating, and at the end, the question they asked me was, how do you take this forward? All these discussions, the research discussions, the students exchange discussions, and then the education discussions. How do we take them forward? I think that is very important as a working group and then as individuals in the working group.
No, absolutely, Georgina. One always wants to, you know, focus on that so that it doesn't just become a yearly conference. So we have 3 subcommittees, and there has been a dilemma whether the group, how many broad, besides the subcommittees meeting, and they're active in various ways, should this group meet as a whole bi-monthly? And we started doing that. Elsie, you may recall, we were going to have CUGH organize one and AFREhealth organize one. That's an important point. So the subcommittee certainly should try and meet fairly regularly and with participation on both sides. But should the whole group meet as well? And if so, under what auspices and how regularly? Elsie, did you have thoughts on that? And Georgina and the AFREhealth group? I mean, everyone would argue, well, we've got so many meetings going anyway, but I think where momentum can get lost is if the subcommittees are just working, that's fine. That's where most of the work gets done. But maybe there should be scope for maybe quarterly or bi-yearly meetings of the whole group. I'm not sure. On the other hand, we do have 2 meetings every year, one at CUGH, a satellite, and one at AFREhealth. So that's quite a bit of time for the whole group to meet. So it's a question I pose to the group, whether we need that extra meeting or not, or whether we just delegate that to the annual meetings, of which there are 2, to be sure.
My thought is that the subcommittee, I know the committees are supposed to be meeting quarterly. So if the committees are meeting quarterly, then the bigger group can meet twice so that we don't burden them. Because, I mean, all of us belong to a committee. So the committees would meet quarterly and they will have to work on the actions that or the decisions that they've come up with. They can develop work plans out of that and that will guide their work. Then we would, as a bigger working group, we do meet twice in a year. Yeah. I think that would be good for us. But the thing is, I don't know whether everybody here is a member of the working group. Because the satellites, at times we get people attending because they are interested in what we are discussing. So that is why Clara has put in the chat box that those who want to join us should send their information to us through our email address so that we can get in touch with them. And then when meetings are being organized, we can reach out to them. Thank you.
Thank you, Georgina. The other point is AFREhealth has a place on the CUGH website, not AFREhealth and the ACWG, this working group. The AFREhealth-CUGH work has a spot on the CUGH site where people can see, and we should talk to CUGH and the CUGH members on the call to maybe open up the members on that site. We do that for some of the other working groups. My question, Georgina, to you is, and I haven't looked at the site closely enough recently, but maybe on the AFREhealth side, you should have an area on the website for this group as well, ACWG. And maybe there could be more communication on the website, or at least members can join up. What do you think? Or do you have that on your website?
We would look at that because that's a very good idea. So we would also add.
Elsie, did you want to say something?
No, I think it's a good idea to what has been suggested. Having we've tried to have the team meet more frequently. It has not worked, but I know that we've always succeeded as the whole group meeting at our conferences, whether virtual or face-to-face. So I think we should make sure that continues, and what has been suggested by Georgina, I think, is a great idea. There's also going to be a change in the leadership of the group. So your side, you've already introduced, at least given us the name, although we have not met her. But on our side, we haven't decided on who's going to lead. So we need to do that as AFREhealth, because I think there should be some change on our side. We've been dealing this with Abigail and myself, and I think we need some new people to bring in new ideas, and we'll talk about that at AFREhealth and give you the way forward. Thank you.
Yeah, I think the CUGH model is that the previous chairs, like myself, will remain on the committee and provide guidance, but the incoming chair on the CUGH side is Catherine Chu, who's a professor of surgery at Stellenbosch. And she hasn't been that involved in this group, but she was on the meeting earlier today. So we should keep that in mind as we move forward, definitely. And definitely have a space at the AFREhealth meeting for this group to meet, Elsie. I don't know if you're organizing the meeting or Georgina or whoever.
Yeah, we will make sure.
Okay.
Sorry, we will make sure that we meet at AFREhealth.
You know, one final thought, which is just, I have not seen any major public recognition of Paul Farmer anywhere yet. I hope the formal meeting of CUGH will do so, but I wonder if there is something we could do as a group as well, perhaps in combination with the medical school in Rwanda. His legacy is enormous, particularly in the equity debate, and I just wanted to put that on the list.
Mary is a member of the CUGH board, and I definitely, there's been a lot of discussion about it. Ines Benaguayo is on the board, and there will be a Paul Farmer Award, and there will be recognition at the main meeting. So absolutely, that is not being forgotten. He will be very much recognized. So thank you for raising that.
Quentin, I have something to say, sorry about that. There is the regional CUGH meeting that is being organized, headed by Stellenbosch. Probably we could ensure we publicize it more so that people know about it and actively participate.
Yeah, thank you, Faith. That is in October. It's a little, I'm not sure I can attend that. It's too many meetings back and forth, but that is also a big discussion on the CUGH board about, it's been going on for many years, about taking CUGH outside North America into regional conferences. The major constraint on that is financial. But I will just reassure everyone here that is not a discussion that has not come up. It's come up year after year after year, and it's difficult to know how to do it. The latest suggestion was to have maybe consider the conference every 3 years or outside of North America. So anyway, but definitely regional conferences are going to be something that will be happening increasingly. Any other thoughts? We have 2 more minutes. There are some people who have not had a chance to speak. This is your chance. But otherwise, maybe in the interest of time, we have to wrap up. There are lots of other satellites. I want to encourage everyone, seeing decolonization came up so frequently. There is a satellite tomorrow, and there are probably more on decolonization, on the role of the humanities, many other satellites. This is a great model, the satellite. I'm pushing at CUGH to keep the satellites over a period of 10 days, because it allows much more equitable participation in the activities, and you don't have to pay for them, you can attend them free. So make use of these satellite meetings. They are helpful for expanding the debate. Any other comments? Elsie, Georgina, Judy from AFREhealth?
Maybe just to say thank you very much, Quentin, on behalf of CUGH, for giving this ACWG team a slot to be able to discuss issues that are really pertinent to both sides. So I think this is a very important group, and I can see more and more people joining and discussing issues that are very important to us. So thank you to the CUGH leadership for allowing this to happen. And even AFREhealth is willing to continue with the discussions, and we'll make sure that we provide space at the AFREhealth meeting to have these discussions. Thank you. Over to you.
Thank you, Elsie. It's been very valuable working with AFREhealth. I'm so glad we initiated that contact in 2017, 18, somewhere there, at the AFREhealth meeting. It's been productive, and it's necessary, and we will forge forth through all the predicaments facing global health currently. We'll persevere. So thank you, everyone. We're going to end dead on time or 1 minute after, but it's thank you everyone for participating. Thank you for the great keynote speaker, facilitators, and please keep the subcommittees working. And for those of you attending AFREhealth, I look forward to seeing you there in August in Harare, and otherwise during the year at meetings. All right, with that, we'll close the meeting.
Thank you very much.
Bye, everyone.
Bye, everyone.